A production fee for your Hometown Health Connection was made by Buffalo Healthy Living Magazine and its sponsors.
Colorectal cancer is not something people feel comfortable talking about, even with their medical provider, but they should. Excluding skin cancers, colorectal cancer is the third most common cancer diagnosed in both men and women in the U.S. The American Cancer Society's estimates for the number of colorectal cancer cases in the U.S. for 2022 are almost 107,000 new cases of colon cancer and 45,000 new cases of rectal cancer. The rate of people being diagnosed with colon or rectal cancer each year has dropped since the mid-'80s as more people are getting screened and changing their lifestyle-related risk factors. From 2013 to 2017, incident rates dropped by about 1% each year, mostly in older adults, while incident among younger adults has increased every year by 2% in people younger than 50 and 1% in people 50 to 64. The lifetime risk of developing colorectal cancer is about 1 in 23 or 4.3% for men and 1 in 25 or 4% for women. In the U.S., colorectal cancer is the third leading cause of cancer-related deaths in men and in women, and the second most common cause of cancer deaths when men and women are combined. It's expected to cause over 52,000 deaths during 2022. The good news is that the death rate from colorectal cancer has been dropping in both men and women for several decades. One reason is the colorectal polyps are now being found more often by screening and removed before they can develop into cancers. Those cancers are being found earlier when they are easier to treat. In addition, treatments for colorectal cancer have improved over the last few decades. There are now more than 1.5 million survivors of colorectal cancer in the U.S. On this edition of your Hometown Health Connection, we will get important life-saving information you need to know from a woman who is a colorectal surgeon leading the way to help us all on this edition of your Hometown Health Connection. I am Kate Glazer. Welcome to the program. Today you're going to meet with Dr. Jessica Martinolich, a board-certified general and colorectal surgeon with General Physician PC in partnership with UBMD Surgery. She specializes in diseases of the colon, rectum, and anus with a special interest in disorders of the pelvic floor. Dr. Martinolich is trained in minimally invasive techniques, including laparoscopic and transanal surgery, in addition to traditional open surgery. Welcome, Dr. Martinolich, to the program.
Hi, thank you so much for having me.
Thank you. So we're talking about colon cancer. What is colon cancer?
Colon cancer is an abnormality within the colon that typically begins as a small polyp where a segment of cells have reproduced abnormally. And ultimately, they develop into something more abnormal and a malignancy or cancer.
Okay, and what actually causes colon cancer to happen?
That's a very good question. We don't know all of the answers, but as I said, it's an abnormality within the cells, and either that can be preceded by a hereditary disorder within a family that causes an irregularity in the genes of the cells within the colon. We also found that there are some risk factors within our everyday life, so diet, exercise, smoking, all have some impact in increasing the risk of colon cancer.
Okay, so you don't really hear colon cancer too much, a little bit, but how common is colon cancer for those that are a little bit older?
Yeah, it's actually unfortunately quite common. We anticipate this year to diagnose 100,000 people within the United States with colon cancer and a little over 40,000 people with rectal cancer. Particularly, it is more common in patients as you get older, but more recently we've been seeing younger patients diagnosed as well.
So you say younger, what does that mean? Is that people in their 20s and 30s getting colon cancer?
Patients under 50 years of age, from 35 to 50 years old have been increasing. We've seen increase in diagnosis of about 2% per year.
Wow.
Yeah.
Are there certain ethnic groups that it's more prevalent in?
Yeah, we do know that African American patients have a higher incidence of colon and rectal cancer, and unfortunately tend to be diagnosed at later stages as well.
Okay. And why are more people who are younger getting colon cancer? Do you know of anything that's kind of causing that?
I wish that I did, and I would counsel everyone against it, but we don't really know why currently. Like I mentioned, there are certainly environmental factors that seem to be attributing to development of colon cancer, and in particular diet, specifically high fat, low fiber, low folate, low calcium diets seem to be associated with a higher incidence of colon and rectal cancer, as well as smoking, alcohol intake, and a sedentary lifestyle. All seem to increase the risk of colon cancer, and maybe why we're seeing this in younger patients, but we really can't be sure.
Okay. Chadwick Boseman, the actor who starred in the Black Panther, he was one of the most just this actor out there that passed from colon cancer. Did his death bring more attention to colon cancer, and what have you seen personally here locally with that?
Yeah, I think it certainly did, nationally and locally. I think seeing such a prevalent, well-appearing young male pass in his early 40s from such a scary disease that really I do think is typically associated with older patients, I think opened up a lot of people's eyes to the fact that this is unfortunately a lot more prevalent in our society than we previously realized.
And he was a little bit silent about it, but then when he actually did pass, there was just so much buzz about it. So did you actually have patients come in saying they had seen his passing and they wanted to get screened? How did that happen?
Yeah, actually I have seen several patients who were kind of triggered by this concern, particularly patients on the younger side, and particularly patients who notice that maybe they have some symptoms that make them at higher risk.
So you talk symptoms. Let's touch on that a little bit, just so people are aware out there, what they should be looking for.
Yeah, certainly. Unfortunately, the majority of cancers are diagnosed, or fortunately, I guess, are diagnosed incidentally on colonoscopy. But some patients, in particular, the things you want to worry about are bleeding per rectum, so noticing blood in your stool, around the stool, in the toilet bowl, change in the bowel habits, so difficulty with constipation that maybe had never happened previously, or change in the caliber of stool, which is such a funny thing to talk about, but if you notice that that has changed over time, that's a reason to see your physician and consider getting a colonoscopy.
Yeah, it's funny to talk about, but it's very, very important, right?
It is.
Who should get screened for colon cancer and when? So I know that you said that screening doesn't typically happen until you're in your 40s, but is that typical? Are you seeing a younger screening? Anything like that?
Yeah, so actually very recently, actually less than a year ago in May of last year, the recommendations among many different societies or medical societies has changed the screening for colon cancer to 45 years old from 50 years old. Okay. And New York State now actually will cover screening at 45 years old through insurance. Patients who have a primary family member with a history of colon cancer, so a parent or a sibling, should be screened 10 years before that family member was diagnosed with their disease. So if that's 40 or younger, they should have that done then. And any family member with a history of colon cancer, any patient with a family history of colon cancer should consider getting screened at 40 years old.
Okay. I know you talked diet a little bit, but let's dive more into that. So what is the effect on preventing colon cancer, diet and health style and lifestyle?
In regards to how well can we prevent it?
Yes, absolutely.
We don't know for sure, honestly. We do know that overall the rates of colon cancer have been declining in past years, although this may be more related to colonoscopy screening. But what we do know is that there is a higher frequency of these diets I commented on in patients who are diagnosed with colon cancer. I think a lot of this is unfortunately still in the works, and many research studies have to be done to give us better recommendations. But we know that these high-fat diet, low folate, and low fiber are associated with colon cancer.
Is there anything with exercise that people should be? I'm sure that kind of goes hand in hand with a healthy eating, correct?
Yes, exactly.
Okay. And let's talk colonoscopies, because I know that that's like a scary word for so many people. myself included. What do you suggest is the best method for screening, obviously colonoscopies? Is it really the best method for that?
It really is, but there are other really good options as well. The reason colonoscopy is the best, even though it has a really scary aura about it, as you mentioned, is that it's not just a diagnostic tool, but it's also a therapeutic tool. So at the time of a colonoscopy, if polyps are identified or even an early cancer is identified, there's a potential that it can be removed and prevent the development of cancer later on.
Okay, let's talk more about colonoscopies, some of the misconceptions around colonoscopies, because I think that's a really important topic to kind of discuss. What are people saying when they come in? Are they nervous about it? Talk about the emotion and how you sort of back them down.
Yeah, that's a great question. Colonoscopy is a procedure, and you go to sleep, but you're in a kind of twilight sleep. So you don't experience the pain or discomfort that goes along with the procedure. You will wake up and get to eat a nice breakfast afterwards.
I love that.
The thing that's most difficult about a colonoscopy is the part the day before and the night before where you're cleaning out your colon. And that, you drink some fluid and a medication that helps to clean out the intestine. You do use the bathroom quite a few times, but it's so important because it allows us to adequately see the wall of the colon to identify any even very small millimeter-sized polyps that could, over the course of 10 years, have become a cancer. So that, the prep part is really the most difficult part for patients. But then when you come for the procedure, you get a nice nap.
And you said a nice breakfast after.
Yes.
Which I love. So we will have more life-saving information after a short break with information you need to know. If you want to connect with Dr. Jessica Martinolich, we will want to give you an important number you need to write down and call for an appointment at one of several locations in Western New York. Connect with General Physician PC at 716-636-9004 or online at gppconline.com. Don't hesitate to reach out if you need to get a colonoscopy or may have a reason to believe you might be at risk for colon cancer. It's a call and online search that could save your life. We'll be right back.
Buffalo Healthy Living Magazine is a free, full-color magazine distributed throughout Western New York. Now, more than ever, as we all want our families and friends to be safe and well, Buffalo Healthy Living Magazine is devoted to health, fitness, and nutrition for people of all ages. It's a great read and also has great recipes. Pick up Buffalo Healthy Living Magazine all over our hometown or go online anytime at buffalohealthyliving.com.
Welcome back to your Hometown Health Connection. I am Kate Glazer. We are continuing our conversation about colon cancer. According to cancer.gov, since the 1990s, the rate of colorectal cancer has more than doubled among adults younger than 50. Not only that, but more younger people are dying from the disease. This rapid increase is especially puzzling because the rate of colorectal cancer has plummeted among older adults, largely due to regular colonoscopies and lower rates of smoking. Experts don't know what's causing the jump in colorectal cancer among young adults, but they do know some factors that raise the risk of colorectal cancer in older adults, including obesity, physical inactivity, and smoking. We continue our conversation now with Dr. Jessica Martinolich, a colorectal surgeon with General Physician PC. Doctor, we talked a little bit about colonoscopies, so just want to go back to that a little bit. What are you doing on your end? It's so interesting to me because many people don't know. So on your end, what exactly are you doing when we're kind of having this nap that you say?
Yeah, so the goal of the colonoscopy is to assess the interior portion of the colon. The colon is about 4 to 5 feet long, depending on the patient. And we use a small camera. It's about slightly larger than the size of my index finger in regards to its diameter. And it's entered through the anus and advanced through the entirety of the large bowel up to the level where the small intestine meets the large intestine, which is right where the appendix is. And that allows us to assess the entirety of the wall of the colon for any abnormalities. If we see, as I mentioned, polyps or irregularities, we can remove those at the time of the colonoscopy.
Oh, wow, okay.
And you would typically hear back from your physician in about 7 to 10 days on the results of the biopsies, if they were taken or if there are any abnormalities found. The whole procedure takes about 30 to 45 minutes. And during that time, you are asleep in this twilight sleep, but it's not a full anesthesia, which is concerning for some people, to the fact that they're getting some level of anesthesia.
Sure.
But overall, the reason I mentioned that it's really the best option that we have is that we can remove problems before they become a cancer.
Is there any pain after the procedure is done?
Yeah, so some people will feel some abdominal bloating afterwards, and this has actually changed recently with the type of insufflation that we use. We have to inflate the colon just a bit so that we can adequately see the wall of the colon, and that's why people get some bloating afterwards. But with these changes recently made, that air gets reabsorbed a lot quicker. So even in the last 10 years, there's been advances in colonoscopy that make it much more comfortable for patients.
Wonderful. Are there any other methods or screening options?
Yeah, there are, and really beneficial ones, I would add. However, they're not therapeutic. A Cologuard or fecal occult blood test with a DNA test of the stool can be done. This can be sent to your home. You send a stool sample back, and results go to your doctor as to whether there's anything concerning in the stool, which would suggest that maybe there is a polyp or even a cancer.
Okay.
If there is found to be an abnormality in your stool test, then that would trigger you to then go get a colonoscopy for formal diagnosis. These stool tests or Cologuard or FIT tests can be done every 1 to 3 years, depending on the test that you're doing. So it's more frequent than a colonoscopy, but in many cases it can avoid you from needing to get a colonoscopy.
I was going to ask that question. How often do you have to get a colonoscopy?
Yes, so typically about every 10 years.
Okay.
And that will change depending on what was found at the time of your colonoscopy. If you have more polyps, we should do it more frequently to ensure no new ones are growing. But in best case scenario is every 10 years, which is pretty good.
Yes, and is there a cutoff point? I mean, is there a certain age you get to where you don't need them any longer?
Yeah, that's a really good question, because that's kind of changing as well recently, especially as our lifespan is increasing in the United States, and people are very active later into their lives. So historically, the cutoff was 75 years old, but really it's a discussion between the patient and the physician. And if you're living a great, active, busy lifestyle after 75 years old, there's no reason to stop screening, because we would be able to find something that could be easily managed before it became a bigger problem.
Yeah, it's all about preventing, right? And as opposed to treating something that already is happening.
Exactly.
What is the prep for a colonoscopy? That is one thing I wanted to ask as well.
Yeah, very good question. There are several different ways we can do prep, but typically it's drinking a laxative. And it's typically split into 2 parts, so you drink, or 3 parts. You drink part of it the evening before the procedure and part of it the morning of, as well as some tablets, which all help to cleanse the colon.
Anything else you have your patients sort of follow in preparation for the colonoscopy?
Yeah, so the day before the procedure, they would just drink liquids. Again, we're trying to prevent stool buildup and particles from developing in the colon, and not eating or drinking anything very red within about 3 to 5 days beforehand. And the reason for that is we can confuse us for blood.
That's very interesting. That's a really good thing to bring up. I would never have thought of that. How has it changed over the years? You said that it's actually gotten a lot better. That's one thing that you mentioned. Can you expand on that?
Yeah, so we used to use just air for insufflation of the colon. Now we use carbon dioxide, which is more easily reabsorbed into the intestinal wall, and therefore less distension and bloating and discomfort afterwards. The cameras that I mentioned, those long cameras that are about the size of my finger, are a little bit easier to maneuver, and therefore the procedures can be done quicker. And overall, it's just better tolerated. The prep is less fluid to drink, and patients are typically out within about 30 to 45 minutes, so it's easy on that end.
That's so fast. That's so fast. Do women feel more comfortable seeing a female? I know that's something that we had talked about. Now that you're working where you're working, and do you have patients come in and say, I would prefer to see a female, kind of for these colonoscopies and things like that?
Yeah, I have heard that. I think that there is, particularly when you're working in this field of medicine, there's something that feels very private. And I think sometimes women feel more comfortable with a female physician, but at the same time, I would say that any physician who is trained in colonoscopy will give you the same great care. And there's certainly no reason to feel abashed, although it's easy to.
Right. I do sense that it's really a private type of condition in a way. So I think that having a female option is always a good thing, right?
Yeah, I hope so.
Absolutely. Speaking of females, is there a prevalence of cancer in women on the rise today at all? And if so, why?
There is, there's slightly lower rates of colon cancer in females as compared to men. Over lifespan, there's a 4% risk of colon cancer in women and 4.3% in men. But we do see that this is slightly increasing in women. Again, we don't really have a good answer for that at this time.
Okay. And are there any risks associated with getting a colonoscopy?
There are very low risks.
Sure.
So discomfort is the first. The second is missing something. So not seeing a small little polyp that's sitting there. And that's why we recommend colonoscopy every 10 years, so that if something is developing over that time, we can catch it at the next colonoscopy. Or other risks that are much less common and nothing that people really need to worry about are bleeding, particularly if a polyp is resected, or injury to the colon wall. Both of those things happen less than 0.5% of the time, so very infrequent. And it's something that your physician would talk with you about afterwards if they have concern that that may be your situation.
Sure.
But certainly, I wouldn't say a reason to forego a colonoscopy.
Yeah, very, very important. And in your experience, has colorectal cancer screening saved your own patients through early detection?
Yes, definitely. I've seen many patients who have a cancer diagnosed incidentally on a screening colonoscopy. They had no symptoms, no bleeding, no pain, no change in their bowel habits, as I mentioned, and a cancer was found at the time of their colonoscopy. And often when a cancer is diagnosed early, the only intervention that you need is surgery. Now, it's easy for me to say only. Surgery does sound scary, but one of the reasons I love treating colon cancer is that in the majority of cases, you can surgically remove the cancer, and then that's it.
Wow.
You're cured of your cancer.
So it's not going through the chemotherapy unless it's progressed even further, correct?
Correct, yeah.
Okay. And you're so passionate about what you do. This is something that, not many females, I would think, get into this line of work. What inspired you to do this? And now you're saving lives every single day. What is so meaningful to you with that?
Well, thank you for saying that. I think colon and rectal surgery is a really amazing field because we have a lot of a broad spectrum of diseases that we treat. And particularly with colon and rectal cancer, it is so often something that we can treat either before it's become a cancer with colonoscopy, or treat it with surgery and essentially cure the disease. Or if even chemotherapy is needed, there's survival rates, even in the last 10 to 20 years, have significantly improved with the medications that our oncologists are able to provide to patients. So it's unfortunately a very prevalent disease in our society, but we have a lot of great ways to treat it when it's caught early. Outside of cancer, colon and rectal surgery, we can treat patients with problems like fecal incontinence, rectal prolapse, Crohn's disease, ulcerative colitis, a lot of diseases that can be very bothersome and difficult to talk about, even hemorrhoids or anal fissures that are, really hard to bring up even to your primary doctor. Sometimes it's scary for patients to talk about this, and I think it's really great to be able to make someone feel comfortable about a problem that they've potentially been suffering with for years and fix it.
Thank you for joining us, doctor, with some important information about colonoscopies, colon cancer, and life-saving medical advice. Thank you so much.
Thanks for having me.
If you want to connect with Dr. Jessica Martinolich, we want to give you an important number you need to write down and call for an appointment at one of several locations in Western New York. Connect with General Physician PC at 636-9004 or online at gppconline.com. Don't hesitate to reach out if you need to get a colonoscopy or may have reason to believe you might be at risk for colon cancer. It's a call and online search that could save your life. Thanks for watching. Be safe and be well.
A production fee for the preceding presentation of Your Hometown Health Connection was made by Buffalo Healthy Living Magazine and its sponsors.